So the next presentation is Dr. Teresa Carman. We are modifying her title, but she's going to be talking about ulcers and recurrence of ulcers.
What did you say I was going to talk about? You forgot. All right, so I was given the task of talking about what was it again?
Recurrence, prevention of ulcer recurrence.
Prevention of ulcer recurrence. But if you were here yesterday afternoon, you know that Dr. Meyer talked about that. So I took a little bit of liberty, and I'm going to talk a little bit about diabetic foot management, and I'm going to go through somewhat of a stepwise approach. And I think a lot of this is intuitive, but I want to make some relatively key points. So we know when we talk about diabetic foot ulcers, the risk to our diabetics for ulcers in and of itself is about 25%. And that, honestly, that risk doesn't matter what the ABI is. Any patient with diabetes, you can see on the right-hand part of the slide, if they have diabetes, they are at higher risk than somebody just with PAD alone. There's a 5-fold increase in critical limb ischemia. There's about a 6-fold increase in gangrene. And if you look at it, about a 10-fold increased risk of amputation in patients with diabetes compared to your non-diabetic patients. So these are at-risk patients. The magnitude of the risk or the complications that you see really are a very complex process. And we talk a lot about the relationship and the role of peripheral arterial disease in this conference and in many conferences. But please don't forget, if the diabetic foot, it's really that neuropathy that contributes. And it's not just the sensory neuropathy that we're all aware of, but there's the motor neuropathy that creates that risk for Charcot. It's the neuropathy that creates the risk for midfoot deformity, for loss of the lumbrical muscles, and then the autonomic neuropathy that helps us regulate our skin perfusion and helps us regulate sweating and lubrication, and all that complex process is really where we get ourselves into trouble. So when we look, we have altered shear forces, we have altered biomechanics. So we end up with patients with loss of lumbrical muscles. They have pressure over their plantar aspects, pressure over a hallux, they've got cocked down toe tips, and they've got dorsal parts of their toes that'll rub against their shoes. All of these creating those biomechanical issues that we deal with. We've got the neuropathic changes, which again are sensory and autonomic. Of course, we've got the arterial insufficiency in many of these patients, leaving us at risk for ischemic changes. And then even when we have patients and we reperfuse them and we take good care of them, we've got at-risk healing because of impaired leukocyte function and disturbances at the level of the small vessels in many of these patients. This microcirculatory failure gets a lot of discussion. This is not necessarily related to that large vessel disease, but that's a small vessel disease that we talk about. This sympathetic denervation that leads to arterial venous shunting or capillary steal. There's vasodilation, so there's increased venous pressures. And then structural changes, thickening of the basic membrane and arteriolar hyaluronization, which leads to some small vessel perfusion issues. So step one, how do we identify these patients? Well, honestly, an ounce of prevention is worth a pound of cure. These shoes have to come off at every visit. And I'm going to suspect that when you see a patient in a cardiology practice for carotid disease or for coronary disease or for renal disease, the shoes aren't coming off, but they need to. They need to come off at every family medicine visit. They need to come off at every endocrinology visit, every vascular visit, and every cardiology visit, because you will find those changes that the patient takes for granted or that we don't know are even there, that's going to put the patient at risk. Obviously, a pulse exam, we can ask about claudication and rest pain, we can ask about wounds, but I think we need to be doing a pulse exam and we need to proceed with our non-invasive testing when it's appropriate. Ask the patient if they get regular podiatric care. All of these patients should see a podiatrist on a regular basis, somebody who's qualified not to just trim their nails, but actually do a good foot assessment, do a good quality assessment of their perfusion, do a good quality assessment of their neuropathy, and help provide footwear that's going to be accommodative to these patients and provide them education so they can also be their own best advocate. It really does take a village, and we've heard this over and over, that it takes a village to manage CLI, but it takes a village to manage just a diabetic foot, whether it's got CLI associated with it or not. The patient has to be involved. They have to be encouraged to do their daily foot inspection. They have to have a spouse or a partner or use a mirror. If they don't have good vision, this obviously becomes a problem, and it's part and parcel to that whole vascular condition that we see in these patients. Ill-fitting shoes are a particular problem. Look at your patient's shoes. If they're worn, if they have exposed seams, those are accidents waiting to happen. Look inside for foreign bodies. You will be amazed what you find in shoes, right? You may find shoes, coins, keys, toys, you name it. I've found it in these patients. Obviously, a pulse exam, establish your baseline perfusion, use your handheld Doppler, use your PVR and your vascular lab to help you with this, and we'll talk about that a little bit more. Again, encourage that regular podiatric care so they have a good foot assessment. Calluses are considered pre-ulcerative lesions in your diabetics. If you see calluses over bony prominences, that tells you there's wear and tear, and we need to get those patients offloaded and taken care of. Establish a regular relationship with a podorthotist. You can advocate for the shoe gear. You can be the one who orders that, albeit there are some caveats, and I'm going to go over what CMS tells us about shoe gear next. So there's a very simple, very easy to use tool that you can incorporate, maybe already incorporated into your EMRs. And if even one of these is checkboxed yes, your patient is at risk for an ulcer, for a wound, puts their foot or their limb at risk. So we need to get this incorporated to the EMR, take the shoes off, look for the very basics. Well, what about offloading? Offloading is really our mainstay. We'll see all of these changes where we'll have pressure points over the heel or over the metatarsal heads, pressure points over the toe tips or the dorsum of the toe, and of course that Charcot arthropathy that we're all very familiar with. CMS has fairly stringent offloading guidelines. Unfortunately, so the need for your therapeutic shoe needs to be certified by an MD or a DO who has primary responsibility for managing the patient's diabetes. What does that mean? That means you can treat their CLI, but you have to engage the PCP and the endocrinologist because they have to order the shoes. They have to sign and say, I'm taking care of the diabetes. The patient has a comprehensive program and I'm involved. On top of that, it has to be documented that they have the presence of one or more of the following. So a previous amputation, a history of foot ulceration, history of a pre-ulcerative callus, neuropathy and callus formation, foot deformity, or poor circulation. So what does that mean? Engage the podiatrist, because many times the endocrinologist, the primary care doc, may not be comfortable doing this. I do a lot of wound care, so I will order the shoes, but I know that at that point I have to get the podiatrist, I don't have to get the podiatrist, I can document the calluses and things, but I have to get the endocrinologist to actually sign the paperwork. It has to go to their office. These are just more of the caveats from CMS. Obviously, they're very extensive, they're very rigid, they can be done. A good podorthotist will actually already have the patient engaged, the endocrinologist engaged, and the primary care doc engaged and be very helpful in this whole process. There's a lot of standardized paperwork that gets involved. All right, step 2, what if we have an ulcer? Well, again, we've got to talk to the team. We've got to circle back and say to the primary care doc, the endocrinologist, right, I need a good hemoglobin A1C controlled. I need all the risk factors modified. The patient needs to stop smoking. They need to be on an aspirin. They need to be on a statin. Then you can refer to your wound care specialist, establish their vascular status, and then determine whether or not you need infectious disease, you need a nutrition consult, do we need physical therapy, do I need to worry about their foot and ankle function, do I need to worry how safe they are if I put them into an orthotic or I put them into an offloading device, am I going to put them at risk for falls or trauma? Get your podorthotist involved to help you with the most aggressive offloading that the patient can tolerate. We always begin every assessment with these patients with a general clinical wellness exam. When I trained at Mayo, I was basically told you may only get to contact a patient one time. Do your best effort for that patient. So when I bring a patient into the wound clinic, I listen for carotid bruits, I listen for aortic bruits, I go through the whole patient. Now, I'm a vascular doctor, so that's what I do. But I will tell you, I send about 3 people a year to carotid endarterectomy from the wound clinic because if they come with CLI, they also come with other vascular disease, and it's very important to identify all of that. Use your handheld Doppler. Triphasic, biphasic exams are very helpful, very encouraging, but if you have a monophasic Doppler, stop there, don't debride, get the patient to further assessment, get them into the vascular lab, do your ABIs, your toe brachial index, pulse volume recording for the patients with diabetes who have calcified vessels. And then don't forget about using your more advanced imaging as you go through your whole diagnostic strategy. I always tell patients that wounds are like growing grass. Patients don't understand when you tell them they just can't walk. But I tell them it's like growing grass, and it really is, right? You need to provide all of the basics, just the right milieu at the base of the wound. You need to provide the appropriate amount of arterial inflow so that the wounds can heal. But if they continue to walk on these wounds and they're not offloaded, you will never heal them, no matter how good of a job you guys do with revascularization. And offloading needs to be very aggressive. I tell them even walking a few steps a day is going to impair our wound healing. How do we do this? Total contact casting is the gold standard. Unfortunately, that's a little complicated to put into most wound centers. And when you look, even despite it being the gold standard, it really is suboptimally used. It requires equipment. It requires a trained practitioner. Adaptive footwear is suboptimal, but used very frequently. It provides the most stability for the patient. They are in their own shoes. Darko walkers and things like that, again, I worry about the instability in the patient. I worry about falls. I usually send these folks off to physical therapy, make sure they're appropriately educated on how to walk in these. And if they have Charcot changes, we can usually get a crow walker or a bivalve healing boot covered. Step 3, we're back again now to prevention. Once we heal this wound, what are we going to do? We're going to do the same things. Take the shoes off at every single visit. At this point, if you've got family medicine engaged, you've got endocrinology engaged, cardiovascular medicine engaged, and podiatry engaged, this patient should be seeing somebody on a regular basis. There's multiple opportunities every year to see if there's been a problem, to see if we need to recircle and reevaluate the patient. Be happy to take any questions.
Excellent presentation. My question is, when you talked about doing a carotid screening, is that something routinely you do with people with CLI? You evaluate multiple vascular beds without necessarily having signs like a bruit or no?
I do. As a vascular medicine physician in the wound clinic, I don't care if somebody comes to me with a venous ulcer or if they come with an arterial ulcer or if they come with a vasculitis. They all get a complete head-to-toe exam. And again, I pick up that disease. As our patients get older, I mean, my average venous ulcer patient is, again, in their 60s to 70s. I pick up a lot of carotid disease. And it just puts them into the system. That doesn't mean every patient gets, endarterectomy, but certainly every patient gets on a surveillance pathway. And again, my CLI patients, on average, it's about 3 people a year that I pick up a high-grade carotid stenosis just by listening to the neck. Now, it's hard to explain to the patient why you're listening to the neck when the toe is what they're there for. But I will tell you, at the end of the day, they end up going to the vascular lab. They go to the vascular lab. They get their PVR. They get their carotid. And you circle back and take care of the rest of it.
In our practice, we've been doing it too, but we have sometimes encountered problems with reimbursement, despite the fact that the patient has been very happy with it.
But I think Dr. Carman is saying that she do a physical examination, and then based on her physical examination, if she finds something, then she does the ultrasound.
Correct.
She doesn't do routine ultrasound on every single CLI patient.
Correct.
Yeah, so she does the physical exam. If she finds a bruit, then she needs to find out what's going on, so then she does the ultrasound. Is that correct?
Correct. That is correct. That is correct. These are not screenings. These are patients in whom we document the presence of a bruit, presence of an abdominal bruit, unexplained hypertension with an abdominal bruit. Those are the patients we send for further evaluation.
And as crazy as it sounds, patients really do appreciate that. Just within the last couple of weeks, I sent my fellow in to see a patient, and then I went in to see them, and they weren't there for carotid disease, but I listened to the carotid arteries. And then as I was walking out, the fellow was absent from the room, and the patient said, you really should tell your fellow to listen to my neck also.
That's right. No, I think patients appreciate that you're taking a comprehensive evaluation. Thank you very much. That was a fantastic. Oh, I'm sorry, Dr. Bote. Yeah.
Just echoing that same thing, maybe it was you, Terry, years ago, because I had a patient I did non-invasive, I'm a podiatrist, did non-invasive testing on, which was abnormal. So I sent them over to vascular medicine. and ended up having an endarterectomy, and she came back, you saved my life, you sent me to vascular medicine, for my foot, and I had an endarterectomy. So, but one other question, though, that I'm having difficulty with is getting non-invasive covered. So I had a patient recently, unless they have pain, it's being denied. So I don't know how we can I have to lie and basically say they have pain if I'm suspecting that they have PAD and I'm trying to get non-invasive testing.
So if I don't feel pulses or I hear a monophasic Doppler when I listen with continuous wave, I put it in as a diagnostic code, and I put it in my assessment that they have PAD by exam. And I haven't had non-invasives denied for atherosclerotic lower extremity disease. Now, I don't know. Maybe I don't hear about the denials. But I put what I'm using as my documentation in the EMR, in the medical record, and I use my diagnostic codes to support that.
Okay, great. Thank you very much, and have a safe flight if you have to go.